Hi, good afternoon and welcome to the people in the room and to the people online. I'm Jean-Bernard Mabire. I'm a psychologist and project manager at the Fondation Médéric Alzheimer. I'm very pleased to moderate the first symposium of the Fondation, Psychosocial Intervention in Dementia, a European overview. I thank all the speakers who have accepted to join this symposium. Hélène Jacquemont, the president of the Fondation Médéric Alzheimer. Tabuenca, director of the Fondation Médéric Alzheimer. Andrea Fabbo, head of Cognitive Disorders and Dementia Unit, Health Authority and Services of Modena, Italy, coordinator of Dementia Project. Victoria Tischler, School of Psychology, Faculty of Health and Medical Sciences, University of Surrey. And Martina Roes from the German Center for Neurodegenerative Disease in Germany. Before start the symposium, I'll let the chairwoman of the Fondation, Mrs. Jacquemont, say a few words about the Fondation.
Hello, everybody. Nice to see you this afternoon. Just one word to tell you who is Fondation Médéric Alzheimer. We are a French NGO. We are not a patient organization. For 25 years, we have been promoting social sciences and public health to improve the quality of life of people living with dementia and improve the quality of life of their family caregivers. We have three priorities. First one is the prevention, second is taking care, and third is building together an inclusive society. We aim at producing data on non-pharmacological intervention, on public health and social innovation. Our productions are free and available on our website. I'm very sorry, it's in French, except, and that's the good news of the day, the psychosocial guide, the guide about psychosocial interventions and dementia. It's a good news for you all, and I'm sure you will go and take a look at it. Thank you for all the speakers for their contribution this afternoon, and I'm sure we'll have a very interesting session.
Thank you, Mrs. Jacquemont. Some few words of concepts. Psychosocial intervention are essential to maintain or to improve cognitive, psychological, social, and physical functioning, and moreover, the quality of life of people living with dementia. Psychosocial interventions are also important for family caregivers and professionals. It seems important to us to take a picture of psychosocial intervention in Europe. So during this symposium, we will present the results of a survey we conducted, and I thank people who have already answered. Normally, people online and people in the room who have the app of the conference could respond the response of the answer of the question of the survey on live. About the online survey, it's conducted from July to October. We have 23 respondents, 1 person living with dementia, 2 family caregivers, and 20 professionals. And normally, we will ask to the people online what kind of participants they are. I hope it will be functioning. No. And in the room, are you? Yes. Cross finger. Yes. It's normally it's okay. Yes, it's online participants. Oh, yeah. We have all professionals online. And in the room, who is professional? Okay. Is there family caregivers? Okay. Is there person living with dementia? Yes. Welcome. So it's working. Move on. We ask after the country in our survey. We will have 7 countries: UK, Italy, France, Ireland, Netherlands, Estonia, and 1 friend from Canada. And I will ask the same question to the people online. Portugal and Finland. Nobody in France online is curious. So, just 2 countries online. And in the room, where are you coming from? Italy. Slovenia. Italy. United States. Germany. Some people. So let's start with the first question we ask. The first question is, in your country, are psychosocial interventions integrated into the care and support pathway as soon as a diagnosis is established? Before to show the result of a survey, we will ask to the people online what they think. And you in the room, during the people answer, do you think the response are yes, not? Who think it's yes at the question? Few people. Yes. The no? No? Not systematically? Yeah. The majority. And online. Not systematically. It's yes, 8% no, and 85% of not systematically. And online, it was approximately the same result because we have about 60% of the people who respond not systematically. So I will ask to our speaker if these results are surprising or how it works in their country. Yes. No, it's working.
So, okay. In Italy, this is true. In Italy, not systematically, because in Italy we have 20 different healthcare systems, and not all regional governments have completely organized all the indicators provided by the National Dementia Plan of dates back to 2014. In some health system models, such as Emilia-Romagna region, my region, the psychosocial interventions are integrated in care pathways dedicated to people living with dementia and their carers.
I'm from the UK, and I agree with not systematically. It's very difficult to get a diagnosis of dementia. There's many people living with symptoms of dementia that haven't been diagnosed. And if people are diagnosed, they often rely on memory services, which are part of the National Health Service. And just to say there's important regional variations, and also we have devolved governments in Wales and Scotland as well. So I'm talking about the situation in England. And there's only two psychosocial interventions that are recommended for people with mild to moderate dementia, and that's cognitive stimulation therapy, and also reminiscence therapy it's suggested that could be considered for people with mild to moderate dementia. And the National Institute for Clinical Excellence, that is making suggestions based on gold standard research evidence. However, there's lots of other psychosocial interventions that are available, and there's a guide that I really recommend, which was, it's in its second edition now, produced by the British Psychological Society's Division of Clinical Psychology. And in that, there's over 30 different types of psychosocial intervention. It was developed in consultation with people living with dementia, so it's very easy to understand, and they give the pros and cons of different types of intervention and how people would access them. But most of them are recommended by either the British Psychological Society, the Royal College of Psychiatrists, or the National Institute for Clinical Excellence. So it's very much driven by clinical or psychological provision rather than overall. But there's other charities and providers that offer them as well.
What should I say? What was the question? Sorry. No, I mean, I can second in what the woman from the UK was saying. We have the same situation that we have lots of people with symptoms, probable dementia, but it's not medically diagnosed. And once you're hitting, for example, you're admitted to a nursing home, there's no initiative that you want to secure a diagnosis. So I think it's practically the same what we just heard.
So we finish with French. Like you know, French is a country of pastors, so it's very difficult for social and psychological science to find a place. They are provided but not integrated. One of the reasons is funding and lack of legal framework. One exception is a physical activity, which is recognized by the French health authority. Only activity.
Thank you. Is there some comment in the room? Or some question to the speaker? Yeah.
Sorry, I mean, comment. I'm awake now. I haven't eaten since breakfast, so probably that's the reason why. I think one discussion we have at our side in research is that we have to question what are the fundamental kind of components when we talk about dementia? Because, I mean, depending on the Western civilized kind of understanding, that is primarily a cognition kind of thing. I think we are missing that we may have other understandings of the symptoms that we are relating to dementia. And I think we have to take that into consideration, because if we are saying at the same time that we need an early diagnosis as soon as possible, we also have to take into consideration that people may not see the need, based on their cultural or religious or whatever beliefs, that they have to seek a physician to get a diagnosis based on the symptoms they have experienced and maybe based on the understanding they have about care. So I think if we talk about psychosocial intervention as soon as the diagnosis is established, we also have to reflect on what our general understanding is and the references of when we talk about dementia.
Victoria?
I also just wanted to say that I have a problem with the word intervention, because I think it sounds a very clinical word, and you know, there's lots of other things, psychosocial activities that are beneficial for people living with dementia that perhaps they would benefit from, but because there's not the research evidence underpinning. Are we going to move?
Yeah.
Yeah. It feels weird to talk to people. Yeah. I think we also need to think about the context of research funding, and in the UK, certainly, most research funding goes to pharmacological research in dementia, so people like myself working on psychosocial research, we get a much smaller amount of funding, and it's very difficult to do very rigorous, large-scale research and build the evidence that's required in order to build these interventions and then for them to be recommended more widely.
Thank you. Let's move on to the second question. Here's in your opinion, what is the most commonly provided psychosocial intervention in your country? We will ask to the pool. And on the online survey, they have 3 choices. So we will see after the results. And in the room, according to you, what is the most commonly provided psychosocial intervention in your country? Public? Public ed?
What was it? Sorry.
Public ed? Cognitive stimulation therapy? Support group? Support group? Psychological support? Sorry. Occupational therapy. The pool answer activity, physical, cognitive stimulation therapy, reminiscence, singing, stimulation. Okay. Let's see the results on our survey. As you can see on the survey online, we have a lot of terms for the psychosocial intervention. And if we look at the first choice, physical activity comes first, following by cognitive intervention and daycare center. When I present you the results of this question, I made some category of psychosocial intervention because there is too much answer. In second choice, we have cognitive intervention, support group, dementia cafe, psychological intervention, and intervention for caregivers. And in third choice, we have again cognitive intervention, education and counseling, lifestyles intervention, and art and music therapy. As there is 3 choice, I can't. I put some point because for the first choice I put 3 points, and then for the rest. So it's the cognitive intervention who come first, following by support group, dementia cafe, physical activity, psychological intervention, intervention for caregivers, daycare center, education and counseling, arts and music therapy, social activities, occupational therapy, cognitive assessment, reminiscence therapy, sensory stimulation, and lifestyle. Have you some comments about that, in your opinion, in your country?
Allora, in my country, the most prescribed psychosocial intervention is cognitive stimulation, followed by support intervention for caregiver and the training of staff working in care context. We also try to categorize the psychosocial intervention in 2 groups. Intervention aimed at person living with dementia, intervention aimed at the caregiver, and intervention to the care staff. In Italy, the public health system provides that for people living with dementia and with an exemption code for pathology. In Italy, we have the essential level of assistance is founded by public system. And this public system provided 3 types of intervention for people with the diagnosis of Alzheimer type or other types of dementia. Is cognitive stimulation or memory training in individual or in group, support for daily activities through occupational therapy. I implemented in my context occupational therapy, and the speech therapy for dementia type with the speech languages. The problem is that in Italy, only a few healthcare agencies have applied the ministerial decree due to regional different models. So in the most cases, these activities are not provided directly by the public service, such as memory clinics. In my context, we have the opportunity to give free cognitive stimulation, occupational therapy, and speech therapy, because this is the three non-pharmacological intervention provided by the healthcare system, is founded by public system.
Okay.
But not have any type of intervention.
In the UK, in England, I think CST again is the most common because of the research evidence behind it. But again, very much driven, it's formulated. And I think it's interesting, one of the issues around psychosocial, you could see the diversity of the results. It's quite difficult to categorize what is a psychosocial intervention and what isn't. And going back to that guidance I mentioned from the British Psychological Society, it's really useful because it gives definitions of, what each type of activity or intervention might incorporate. So CST is widely available, but also for people in care homes, it's very much dependent on the staff interests and staff skills and expertise about what's on offer. So it's really variable. And then it's not a formulated model. But I mean, the research evidence is growing, but we don't have strong research evidence for other. So it very much depends where people live and what kind of access to services they have. So there's inequity in terms of access, I would say, in England.
In France, the must provide is cognitive stimulation too, but the practice is very different from the case of Italy, United Kingdom. You find memory workshop, memory training, memory game, but you don't find the stimulation cognitive as original definition. That is the problem.
Based on all what is mentioned here, I would think in Germany we have a strong discussion about relationship-based care, because everything that I'm seeing in these activities goes back to one key component of person-centeredness. I would like to make a distinction between home care, nursing home, and hospital. So I would say in nursing homes, it's primarily leisure activity, a little bit of cognitive stimulation, but primarily I would say reminiscence and folk music. Maybe dancing, and some physical activity which is driven by outdoor. So I would say this is in nursing homes. In home care, it's primarily addressed to the family caregiver, support groups for the family caregiver to reduce burden, not so much to the person with dementia. I think adult daycare center is highly relevant and high-seeked, but not enough services that will be offered in Germany. And in hospital, I would say, I'm a little bit provocative, I would say none, maybe rooming in.
Thank you, Lord. It will be interesting to see the different psychosocial intervention according to the facilities. So. No, just a comment. I think it would be interesting to have a picture of psychosocial intervention according to facilities. Yeah.
In our model, the psychological support of a caregiver is always present.
Okay.
Okay. And these other psychosocial intervention are others, but the support of a caregiver is a criterion, a basic criterion in a memory clinic. In our model, in the memory clinic, work medical, neurologist, geriatrician or psychiatrists, psychologist, and nurse. And we have the possibility to have other as a therapist. But the support of caregiving is a part important of psychosocial of care of people with dementia and caregiver.
Yeah, just following on from that and the point about relational care, I think that's really vital for whatever the intervention is, because unless you have that trust and relationship with the individual, and you need to know what they're interested in, there's no point prescribing something, even if there's evidence for it, if that person isn't interested in that particular activity. So I think the relational aspect is really critical. And I've noticed, even in my research, often the role of the facilitator or the therapist or the caregiver is a really critical part of whatever the intervention is, because it's the way they communicate with the person living with dementia that makes a difference often, as well as the activity.
We can say it's a good intervention for the good people at the good moment. So, the other question, the question 3 is, who advises or prescribes psychosocial intervention in your country? So we let the pool answered. And maybe in the room, some people just have some answer information about this question, according to you.
It's low, this counter. It's very
Yeah.
low.
Nobody online answers. So. And if I ask the question in the room, according to you? Yeah.
I was concerned that social workers weren't on that list.
Can you say what country you're from?
I'm from America, United States.
No, I was concerned not to see social workers or case managers on that list. I found that odd. Are they down there?
Yeah, but I was wondering, can I ask a question?
Yes.
I mean, is it like
There,
a
yeah.
formal
It wasn't on the
prescription you're
other-
talking
now it is,
about?
yeah.
Like, you know, like when I get a pill and then I need a physician that is prescribing me? Or is it more like that we are talking about within the nursing process, I have identified there's a need and then I'm going to decide together with the person with dementia, maybe the family caregiver, that I may need a walk in the garden. So maybe clarify the prescribing a little bit, at least for Germany, I know, because then I would say there's no formal prescription. It's within the nursing process, we do assessment, and then based on the preferences which we identified and the capability maybe of the person and what kind of services are offered, then we decide, it might be the combination of A, B, C, D.
In preparing this question, we have the same question at the Fondation. Because in France, we like prescription, medical prescription, but just adapted physical activity is prescribed. So the other psychosocial intervention are advised. So that's why we put the two verbs.
So, for example, in Germany, just to finish that thought, if I would be in a nursing home, then the nurse would identify the need, and then maybe the occupational therapist is the one who would then conduct the service. So, for example.
I put you the results of the online survey. If you just have a look.
Allora, in Italian context, in the most cases, the prescription is made by professional who work in memory clinics. But the problem is, in other cases, this type of intervention is prescribed independently by volunteers of family association that carry out various support activities. This is, for us, a big problem, because people living with dementia and the caregiver do not have the intervention to which they are entitled based on evidence or cost-effective intervention. In other cases, there are private companies that sell intervention defined as non-pharmacological therapies, whose real effectiveness is very dubious and debated. For this reason, regulation is needed. It's a great ethical problem which has not yet been regulated in Italy.
If you want.
Yeah, I mean, in England, it's very driven by psychology and clinicians, I would say, generally speaking. Yeah.
Okay.
Yes, in France there is no prescription. Maybe only for activity, physical activity, but not in Alzheimer's disease, but in cancer. So there is a confusion between intervention and the practice. For example, the neurologist or geriat can prescribe speech therapy, but not a specific intervention. So, like stimulation cognitive. So, when the speech therapist she is free to provide intervention or not, to choose what kind of intervention she wants. Some professionals, like psychologists, occupational therapists, can advise intervention, but without financial support. But it's another problem we see after.
Yeah, I would hope that as the evidence base grows, that there will be other professionals involved in this area.
So let's move on to the next question. The question 4 was, is there specific training in psychosocial intervention in your country? In waiting the pool, in the room, do you think it's yes? Is there specific training? Who think it's yes? Yeah. Who think it's no? We have a majority of no. It's not a large majority. And in our survey, the result was... it doesn't work. Oh, sorry. Yeah. The answer was yes, and in the pool it was no. And when people say yes, we ask us to give some example of specific training. Do you have some comments about this question?
There's a question in the room. Oh, Esme.
Esme.
Trying to be very, very quiet.
So the first thing I just want to say is that really it's not even interventions to do any psychosocial care, certainly in the UK, is actually gone backwards, and it's very hard. And never mind the evidence base, there's the evidence base, people decide what they're going to do, and they do. There is what Reinhard did, the kind of list of interventions, but one of the complicated things is to try and know what might work for who. And certainly in our last Interdem book of a couple of years ago, we actually worked particularly on algorithms with people and their families to at least make sure that there's somebody to walk with them and give them what they need when they need it through their journey. But people just don't pay attention. And the second thing with training is that it is so very vague, some of this. It's meaningless, and training without coaching and walking with people and making sure what fits and doesn't fit is very difficult. And certainly Margareta here and I have worked with behavioral concerns or distress for many, many years and worked out how to work and how to coach people and how to support them. And again, when we've just finished a big bit of practice-based work in the UK on whether you want to call it behavioral concerns, challenging behavior, or distress, we find that when you ask all practitioners of all disciplines what first-line interventions they use for this, it's antipsychotics and benzodiazepines. So I think we've got a long way to go. And really, if we're bothered about practice, which I think this seminar is about, then we really need to up our game and look at translation, implementation, and coaching and sustainability. So sorry, the training on its own, we do know, makes no difference because you train people, they don't put it in, they do for a bit, and then they're gone. So sorry.
Never mind. Is there some comment?
From our side? If I look at the yes for Germany, I would say this would be part of the regular qualification for the specific professions that are behind it. You know, the occupational therapist learns different kind of psychosocial intervention than the speech therapist or physiotherapist or the geo nurse. And I think that is what we would probably make a distinction with, are we talking about a formal qualification, you know, that I have a certificate in the end, or is it more like something that goes parallel to my routine care? And if I look at the no, I would say this is more based on, oh, maybe I have a project, maybe I have a leader of a nursing home or a home care agency would say, well, you know, we want to implement this, so I'm going to establish a training. And I would totally agree with what Esme is saying. We have tons of trainings for nurses and everyone who is working in the healthcare system, no matter in which setting, in which care setting. But the implementation is really the big issue. So, I mean, they learn their skills, maybe, but how to translate it into reality, to work with a specific person, that usually is not really supported. So we don't have a mentee program, maybe for the students, but not for the ones who are already highly qualified to see, well, you know, what does it mean for resident A or patient B or, you know, the person I'm taking care of. So I think we have to think it together, like Esme was pointing out. The training is only one component of really to accomplish that we have change in care.
Yeah, I agree with that. And I think we also need to look at it in context of 150,000 vacancies in social care in the UK. And I think for the professional groups, there is training available, but keeping, you know, attracting, recruiting, and keeping really good people working in the sector is a big issue. And so often the care is the basics, and this is something extra. And how do we attract those really good people to come and work in the sector and keep them?
There's two questions.
I think as well, I can only speak from the UK context, but one of the other things is, I think you mentioned the sort of almost postcode lottery that there is. So like having really, really good knowledge of local services needs to be part of it as well, because it's all very well and good saying these interventions work. You need to sort of know, you need to have people who are good at doing the research, finding out what's in their local area, and then being able to disseminate that information.
I think that what is missing by means of non-pharmacological interventions is not to build more detailed ones necessarily, but at first individualized protocols, and second, group discussions between health professionals and caregivers and people living with dementia. Because I've heard it in several presentations here, but also according to my experience, it's really significant for those people to take a feedback, to listen their experience, and afterwards to make more detailed interventions. So not only do significant things and measure their efficacy, and okay, this is not easy to measure the efficacy. There are always confounding factors, etc. I'm sure that you know all of them. But also to take the feedback from those people and to be more tailored, to do more tailored interventions. And feedback from Greece, yes, I agree with all you've mentioned previously. We do CST and cognitive training. Of course, psychoeducational groups and caregivers and support groups are on the top line of our interventions. So we agree, I think, more or less. We are in the same line. But talking about implementation, I think that these two words, individualization and teamwork and feedback, are really significant to be also added. Thank you.
Sorry, we can move to the last question. Was how are funded finance psychosocial intervention in your country? Next. There is some question about perspective after, so we just let the pool answer. But it's an important question. In the room, who think it's public funding? Private funding?
So by public, you think insurance I have paid beforehand and then, yeah, okay. I just want to make sure.
Personal, after public and private. When we speak about public funding, it's like in France, it's covered by the national security. The social security national. You don't pay for services. So we have a majority of personal fundings, and on the survey online, it was almost public funding and personal funding. And what our speakers think about that?
In most cases, in Italy, psychosocial intervention are provided by private individuals or by care organization or family association. The public health system almost always provides psychological support to family members and partly cognitive stimulation. Everything else is left largely to the initiative of the association. Then there are virtuous models, such as Emilia-Romagna, that manage to provide many types of psychosocial intervention for free. The financing of the Dementia National Plan by the Italian Ministry of Health has made it possible to begin to fill this gap, and all regions are working in this direction. New finances for the next 3 years has already been requested from all regions to Italian government. But we need to implement, and we need to research, and we need to work with university for the model that provide in that system.
It's a mixed picture in England. Not so many people have private insurance at the moment. So NHS, the National Health Service, will provide, but as my colleague at the back said, just because they'll provide it doesn't mean it'll be available where you live, or there'll be someone with those skills on offer. So it's a postcode lottery. And there are also charities and other organizations who will offer some of these activities for free or for a subsidized rate. And then there are commercial providers, and there's some risk involved in that as well, because you don't really know, who developed this and, if it's worth paying for.
In France, it's the same. It depends where the person lives. If he lives at home, there is no specific financial support. Maybe with some volunteers or some like charity, but it's very rare. And if he lives in an institute, he can find support financial by the whole budget of the institute. So.
In Germany, I'm just bringing the example with a nursing home. So if I'm employed, I'm paying health and social care in an insurance, and then if I would go into a nursing home based on the costs of the provider, that would be paid out of it. But since the prices, we wouldn't make a distinction unless, and I'm coming back to that, and then, but the prices per bed in a nursing home increased tremendously. For example, at the moment in the state where my parents live, the out-of-the-pocket payment in a nursing home, nothing special, would be around 3,000 euro per month. So you can imagine, both my parents are still living, so for me that would mean 6,000 per month. So I would say I have good salary, but I want to have something for me left as well. So I think that's really an issue, becoming an issue. It didn't used to be that good. So if we talk, and then since we have the health and the social system, so if we talk about the therapeutical kind of sequences you were talking about, like a speech therapist, occupational therapist, physiotherapist, then that needs to be prescribed and that will be paid out of the healthcare system. So, and I think that is what we have to take into consideration. If I would go in a hospital, everything is covered. So I don't have to pay out of pocket. If I'm living at home and I need specific kind of training, then it would be the same as in a nursing home, because only the care that is related to my care level is covered by the insurance. So I think we really have to pay attention, like everyone was saying, to the system we have.
Thank you. Is there any comments in the room?
I think a lot of it in America is volunteer. A lot of people are volunteering.
Everybody heard or not? No, maybe with a micro.
I think in America, oftentimes these are done by volunteers, people who volunteer to do an art class or a support group or a hike or a walk or these kinds of activities. Often people who've retired who are volunteering to help, or young people, or sometimes interns in university programs who might be becoming a allied health professional or something like that. So a lot of it's patched together through volunteer work.
One of our previous governments in the UK did that. They called it the Big Society. And then systematically, alongside that, lots of other organizations were defunded. So things that the government would have provided, well, now we have to rely on volunteers and people doing it for free. I mean, I don't think that's equitable either.
But I think what we have to take, I mean, at least in Germany, to take into consideration, I think it's in the UK the same, is there's a quality assurance, an obligatory quality assurance kind of system. So the question is, I mean, I do know the US system a little bit, but I think what we have to take into consideration is also how will they play into when we measure the quality of the performance of the nursing home, for example. And in Germany, we see there's already a tendency. We have also lots of volunteers, but not specifically in the nursing home or in home care, but they all want to get paid. So at the moment, we already say this is paid volunteer work, you know, because they at least want to have something. And that is primarily driven also by a law of a minimum wage, because, I mean, there's no such as volunteer unless it is private.
Thank you. To conclude, I just want to ask to the speaker two questions. According to you, what obstacles and barriers still exist to accessing and implementing psychosocial intervention, and what could be done to improve the implementation of psychosocial intervention?
In Italy, the main obstacles are the need for formal regulation by government, funding, insufficient economic resource dedicated, and research. Research on psychosocial intervention is essentially unfunded in Italy. It is also a problem of universities that do not train an adequate number of professionals specialized in dementia, although a discussion in this direction has been started. But we are only at the beginning.
I would say inequity of access and lack of a research evidence base, because basically that's what you need to convince people that something is worthwhile. That's not my position, but you know, in order for something to be paid for in England, that's what's expected. And I think things aren't joined up. I mean, we have these new integrated care boards that were introduced, which are supposed to be kind of coordinating services and bringing different services together and making sure that things are coordinated, but it's early days yet, so I'm not sure whether that's going to work very well. It's often politically driven, a lot of these decisions.
In France, we have two obstacles. The first is funding, and the second, the research. We are focused in France in the cure and biomedical research. Biomedical research with an important funding is not the same for the science social.
I agree with everything that has been said so far. I think, I mean, on the top of my head, I always would say it's the resources. You know, I mean, people are willing and they know about the evidence, but they claim they don't have enough time. And I always struggle because I'm coming from implementation science. Is that because we are not providing research results that are close to reality, or is it more like the implementation component which is not addressed enough? And I think one aspect how we can change that, and there has been some kind of good conceptual work and also research that we have to start as intervention researchers. I'm an implementation researcher, and I don't want to start after 17 years when others have worked 17 years on something. I think we really have to change research by starting to include implementation components from the first moment when I think about a new intervention. And I think we all know Mura's work on that one in dementia care, because we already see we have started way too late. You know, I mean, maybe at the feasibility study, but I think we can already start earlier. And one way we see how we can bring intervention in researchers, because they don't want to think about implementation, because they always say it's later, is that we are saying, well, let's do a process evaluation, because then we can focus on what's going on when you do your feasibility study, when you do your RCT, and when you continue, because then they see the benefit. Oh, now it's good that I know what's going on in practice. And I think this is how we can emphasize that we have more reality from the beginning as often as possible. And I think the conference also has showed that we have to bring other people to the table, because then we can bring other ideas to the table and not just what the researchers or the professionals think what might be a good intervention.
Okay. And we have a question online for you. How are possible European strategies to have the same shared psychosocial intervention with the same ways to prescribe them? I will repeat the question. How are possible European strategies to have the same shared psychosocial intervention with the same ways to prescribe them?
Maybe someone in the room wants to have a go at answering that. We have a lot of expertise in the room.
Yeah, let's see the question they're reading.
How are possible European strategies to have the same shared psychosocial interventions with the same ways to prescribe them?
Yeah, that's the core kind of thing, because then we could say, I mean, on the top of my head, of course, I come back to my preference topic, which is person-centered care with relationship-based care. So all the interventions we saw, and I think that is sometimes what we have to provide. It's not about of course, it's about cognitive stimulation, but at the same time, for me, cognitive stimulation can be done by my own or can be done in a group. And I think what we can do, the physical activity also, it could be done by my own, but it also could be done in a group. And I think what we really could use as a combination is what is the person-centered dementia care component, because then we would emphasize it in a different kind of way. And then it's not a single kind of, oh, I'm going to the garden with you, but it's also, oh, we talk, you see someone else, there's something with the senses, there's something with the hearing, with the tasting and everything. And I think if we would be able to bring it into a different perspective, then I'm pretty sure everyone in this room and everyone from the conference, everyone in dementia care research would say, of course, person-centeredness, but we miss the link that actually all the interventions we were talking about have something to do with that and the relationship, which is key, I think, and we can do that. And that could be the shared kind of component. And I guess there is an agreement, but obviously we have an issue to bring it into reality by saying, oh, hold on a second, this is actually person-centered care.
Thank you. Is there any comments or questions in the room? We have just 2 or 3 minutes left. The micro.
Hello, there's a question there. First row. The one with the flower.
Hi, I'm Federica. So mine, more than a question, is a reflection of my opinion. I think one way to improve the implementation of psychosocial intervention is to identify what are the mechanisms underpinning an intervention, because we, the panel discussed the importance of context. Often, our research shows that an intervention is effective, but when we are going to implement in the real world, there are different dynamics that take place, and we don't have, or we cannot find the same impact. So I suppose that if we know this mechanism, then it will be easier to adapt an intervention based on the context, because you know what are the elements that generate supposed to generate the change. So this was my just a comment. Thanks.
Thank you.
I mean, what we could, I like that idea, and I would love to have funding for all the different variation, but I think one issue we have when we talk about the evidence base, which some need, and is needed by, the same, the government is also going, well, evidence, decontextualized. And that is why we always say, well, and that is the reason why I have tons of systematic reviews that in the end always say, well, we need more research because it was different in that study and that study. And the funding agencies are not paying me for repetition in a different context. They always want to have something new, but I think, exactly what you're saying is we would love to do, because we already know that it is not only about the evidence, but it is specifically the different target groups, the different contexts, and we may have the same idea. And by repetition of that error, we're not going to change really practice, because I always need an argument, why can I do it? I can't say, well, they did it, I want to do it. So that's very seldom. And I think that is where we have to impact policy, because, they need to change their rules to fund research that I really can do contextualized kind of research.
Thank you. It's time to conclude. So just a final question, because in French, the Fondation conducted a survey in dementia facilities about psychosocial intervention according to the facilities. And do you think it was really relevant or interesting to have the same kind of survey in Europe? To have a look, or comparative look to what kind of intervention is in the country according to the facilities and according to whom provide the intervention, to have a global look in Europe?
I think it is, but I think it needs to be done on a regular basis because of political changes and policy changes, and things keep shifting and changing. And I really like the point about the implementation. We know there's been lots of studies that have found promising findings in this area, but often that's missing is the implementation. And I was speaking to a delegate yesterday who's starting up a company, as a legacy project to actually sell this as an intervention. So I think that kind of entrepreneurship would be good to increase as well.
For me, it's very important, the regulation and the policy. And universities should check that institutions, agencies, and associations provide high quality and cost-effective intervention. But we are working.
Okay. Thank you. So I think it's time to conclude. So I thank you for your attention. I thank you all the speakers, the people in the room, and the people online. Thank you.